All right, so where we ended up was looking at this is like a 4D data set in the sense that we have about 10 volumes over time through the heart cycle. And each time frame that you see here represents about 160 milliseconds of data, something like that. And when you just play them back to back, those volumes, you get a dynamic view of ventricular function, which is here, for example, and atrial function, which is up here. So you can see how the posterior wall of the atrium is contracting in here. The roof is moving down on each contraction. See that? You can see the strain that happens to the pulmonary veins, where they're coming in. None of this data is used right now to analyze atrial function. And here, if we go to this view, you can see the wall, which is here in between. This would be the anterior wall of the atrium, right? The posterior wall's back here. This is the anterior wall between the two and behind there. And you can see there's a lot of activity, right, in terms of the motion of that during contraction. So there's tons of this data available, and nobody's really taken it and modeled atrial function at the resolution that's available with this data, right? To this point, if you look at atrial function, it's mostly done with echo, either transesophageal echo or with MRI. An MRI, you do this in multiple slices. You'll walk through them, and we'll see how you do cardiac MRI very shortly, okay? So there's tons of functional information here. Look at the right ventricular function here, right atrium. This is the, the pulmonary arteries coming out here. This is the SVC, the superior vena cava, with very high concentration contrast coming down into the heart. So this type of data is not really available with other imaging modalities. Look, take a look at this is the septum in here, and this is the right ventricle. So it's important to understand that the reason that the contrast is so high here is because we've injected a contrast agent into the blood pool. So this image is essentially a movie of the blood pool cast. So we don't see any myocardium because it's been thresholded out in this rendering. And all we're looking at is the blood. And so the blood is making a cast on the wall. So this is the endocardial side of the right ventricle, say this surface right here. And you see the motion of that cast, right? And how that is moving. And so you can use that information to essentially evaluate endocardial function. So all we're seeing with great detail is the endocardium. These are maps of the endocardium. They're all the same endocardium, just looked at from different viewpoints. This is the anterior wall of the left ventricular endocardium. This is looking at the endocardium from the apex, which is here, up towards the base. And then this is the posterior wall. And what's color encoded here is the curvature of the function that we're displaying. So if we consider this function a surface, and then we evaluate the curvature by the second derivative, say, well, where we have high, sharp peaks, right, we'll put a blue color. And so these are the high peaks. And where we have deep valleys, we'll put a red color. And so as you can see, those features are trackable, right? They move in space, and you can actually use those individual features as fiducial markers, in a sense, to track where that tissue is going, right?
Well, they are like rigid. So are they like papillary muscles?
Exactly. So the question is, what are they? Are they papillary muscles? There are two major papillary muscles in the LV, which come out, but these are what's called the trabecular tissue on the endocardium of the left ventricle. I believe I have a slide, which used to be a movie. It stopped working though. Here it is here. Yeah, the media got lost. So this is what the endocardial surface of the left ventricle looks like. And this was done by Medtronic many years ago. where they had a beating heart, they put a oxygenated transparent fluid into the circulatory system so that they could videotape with a camera the motion of the endocardial surface. And so you can see that there's a lot of nooks and crannies in here, and these interesting, fibers that are attached across spaces. This stuff is not really visible when you do MRI. It is if you really go for it in terms of resolution, but it's hard to do. Echo, it's not really visible, but in CT, you can see all of these structures, these fiducial structures, which are the trabecular tissues. Other tissues that are really smooth, like if you look at the descending aorta here, it just has a really smooth surface. And so this is the native smoothness of the data.
Yeah.
So if you were to look at what is the bumpiness of my data, if the actual input is something really smooth, well, that's the bumpiness right there. And that's the noise sort of bumpiness. Here's the ascending aorta, same thing. And the atrium has quite a smooth surface. It doesn't have this trabecular tissue in it. The right ventricle and the left ventricle do have highly trabeculated tissue, and so you can track them.
It's nice to see that it looks like they're striated in the direction of traction.
Yeah, it's interesting, right? There, if you look at the movie, like this one in particular, right? The striations tend to run sort of along the fiber direction, right? So they're going from the base down towards the apex, and you can really appreciate twist, for example. So when the heart contracts and twists, you can pick that up here very well.
They're not muscle fibers themselves.
I bet they are. They probably contract as much as the myocardium does. They're myocytes.
Oh, okay.
For sure, right? Yeah. The thing is, that when you have electrical activation of the tissue through the Purkinje system, that happens more towards the endocardial layer than it does the epicardial layer. And so I'm not sure. The one other interesting thing about this is if you're in the left ventricle, all of these myocytes are in direct contact with LV oxygenated blood, right? So you wonder, how the heck do they die if they're bathed in oxygenated blood, right? So there should be, you would imagine, a layer of cells that survives just because they're in this like bath of really high quality blood. So, however, what usually happens is tissue dies right to the edge of these things, and you get if you have an infarct, it looks something like this. It's just something that has a distension. Usually it's bulged out and it doesn't squeeze down, and so the features don't contract. And so you can track these features, with your favorite tracking software. There's lots of tracking software out there that comes from computer vision and elsewhere, and make a vector field, of the displacements or velocities or whatever your favorite vector field is to look at motion of a point, cloud of points. And so that's what we've done here. And then, in a patch, you calculate, what's the divergence? What's the strain of that cloud? Are the points coming together? Are they getting stretched apart? And color code that. And so this is a color coding of that, displacement field. And then essentially what is the change in surface area, of the point cloud. And so if the change in surface area is, the surface area gets smaller, we encode that with blue. And if the surface area gets bigger, we'll encode that with yellow. And so over the course of systolic contraction, you can see this patch here is going very blue. That means all of the points there are coming together. So at this point, I needed a much larger area to fit all those points than I did over here, right? So it's a strain. And you can also see that at the end of systole, 350 milliseconds into, the R to R interval, there's a bulge right here that really didn't contract that much. I mean, it contracted a little, but it even stretched a little over here. And so that is not normal. The whole thing should go blue, right? The whole thing should contract. This is the endocardial surface of the left ventricle. And to quantify it, so here we have our clouds, point clouds at different times. So you segment out using the CT data, you segment out a surface, which is the LV blood pool surface, endocardial surface. And you do that at multiple times. And then you calculate these displacement fields to go from the 0 time to whatever, say time 5. And then calculate the change in surface area as a function of position on the left ventricle. And that gives you a functional map of the left ventricle. So if there's a chunk that isn't working right, it'll show up as a big yellow thing here. So this is, we performed this in a bunch of people who had CTs for some other reason, or they had a coronary CT and they turned out to be normal. So they had normal function. And when you look at this function, you know, that we're encoding with color, like how it's squeezing together, it's like a strain. And you plot that at different parts of the ventricle. So this is the base of the ventricle, the middle part, and the apex. And you look over time, this is how, say, 25 people, if you plot them one on top of the other, this is the reproducibility of those numbers. This reproducibility absolutely crushes reproducibility of echo and SPECT for sure. MRI, if you do MRI very carefully, you can get the same type of reproducibility, but it's harder.
That's measuring the same thing on echo and MRI, like they're measuring fall motion.
Yep. Yeah, and so this is, we're going to call this a strain. Okay, it's a 1D strain with no directional sensitivity. So basically, you take the area, it gets smaller, take the square root of that, and say, okay, that's 1D strain as opposed to the reduction in area, and plot that. And so it starts with 1. If it stayed at 1, that would mean that piece of tissue did nothing over time. It just stayed at the same area. As it goes down here, you can see this goes down to about, 0.65 is the mean, something like that. That's the amount of reduction.
So that's the area getting 35% smaller.
Right. It's actually if you were to put a one-dimensional marker inside that area and saw how much the 1D marker went down. People don't think in areas, right? If you say, well, what's the area of this room? Nobody can tell you, like, unless they're a real estate agent, they can't tell you the area of the room, but people think in linear distances easily. So you say, like, how long is this room? You go, oh man, it's like 12 meters, boom, and you're done, right? Whereas, and in strain, whenever you report a myocardial strain, it's usually reported as a one-dimensional strain. Oftentimes, it's reported as a one-dimensional strain in a particular direction. So the longitudinal strain is if I put a marker on the heart from the apex to the base and saw how much it shrinks, that's longitudinal strain. Circumferential strain, you put a hoop around the short axis, right? And then radial, you put a line across the wall and see how much it changes. This is an interesting strain. It's like a combination of longitudinal and circumferential because it comes from the surface of the left ventricle. So it's just, how much does that surface shrink down is what we're asking. No direction sensitivity in this. Makes it very robust. And so when you look at the mean and the standard deviation around those 25 people, it's super reproducible. You can then look at very small changes of strain behavior. So in this patient who has early heart failure with preserved ejection fraction, their heart is still producing sort of a 50% ejection fraction. But when you look at their strain curve, you think, you know what? It's significantly different than the strain curve of what would be a normal heart. And here it looks more like it's just half a sine wave, right? It looks like instead of this rapid reduction in myocardial length, it's slowed down. It's a little bit above average, but it's getting in there. And then what also is slowed down is its ability to relax. And so it becomes more like a squeeze box kind of function This is sinusoidal squeeze box as opposed to a normal LV contraction, which has rapid contraction, rapid relaxation, and then rest. That's how that usually goes. So that when you see something like this, you know, this person has delayed relaxation and slower relaxation than a normal. So those are fine, so the fine structure. So I'm not sure why. Oh, okay. So the next application I wanted to look at is looking at atrial fibrillation, and can we say anything if we have their CT cine, can we make some statement about this person's risk, you know, for stroke if either they're an AFib or they're coming in and out of AFib? Are they somebody you should put on, say, warfarin or some blood thinning drug so that they don't throw a stroke or throw a clot? And you can see really good left atrial and left atrial appendage function with CT, as we'll see. And I don't know if I have, we wrote about some papers on how the fibers are organized in the left atrium using a diffusion tensor MRI. We had human hearts from, you know, donors, and we imaged them for like 4 days each. This is the NIH. We put the heart in the scanner, and on like a Friday afternoon, and we came and picked it up, you know, on Monday noon, something like that. So we imaged it that long, and we made these ridiculously high resolution maps of where all the fibers go and everything. It was really cool.
I'll have some questions about that later.
Yeah, sure. It's a really neat data set. I still have the data set. I haven't put it up online, but we should soon. But anyway, if you have a patient who you're trying to decide, you know, should I put this patient on a blood thinner or not? What is their propensity to have a stroke from thrombus in their left atrium and left atrial appendage? What is used now is this thing called the CHADS-VAS score, or this one's the second one. And if you look at what goes into this score, it's their age. Obviously, they higher risk as they get older. I can't remember which one is. Oh, female, you get a +1. So it's obviously a higher risk to be female. Did you have congestive heart failure, hypertension history, previous stroke? That makes sense, right? Vascular disease history. Do you have coronary stuff, and diabetes? So these are all clinical things, none of which actually address the question, how is the left atrium and the left atrial appendage in this patient functioning, right? It's all just clinical history. And this score is not that great at being accurate, unfortunately. But that's the state of the art. So the question is, you know, if you've got a CT movie and you can look at this patient's left atrium, like with this kind of detail, shouldn't you use this information to decide whether or not the blood flow in this left atrium is compromised and could lead to a stroke? And so you can see this is a cine of 1 heartbeat, and this patient is not in atrial fibrillation because their atrium, if you look at the top of it right here, it goes boom, it contracts, and so it actually has a P wave and a normal atrial contraction here. If you're wondering, those of you who are really sensitive to data, you see how these dark kind of artifacts come in this pulmonary vein here. That is the end of the contrast, basically. So the contrast coming in this pulmonary vein has a lower concentration than it did at the beginning of this heartbeat, right? And so you're seeing this flow because it's blood with far less contrast in it coming in. It's almost like the saline chaser or something coming in after it, right? So there's a whole field you could make up a whole research field of your own, just saying, how could I model these pulses of different concentration to measure flow? You know, think of it in the positive direction. If you just put a little puff of concentration, not filling the whole blood pool, just put a puff and then watch that thing go around the heart, right? It would be kind of cool.
What if you could do like multiple pulses of contrast?
Absolutely. Right. So the next question is, well, one pulse of contrast is one function you could use. It's a simple function. It's like a square wave, top hat. What if I use some really complex function that encoded various, flows? And so you could use a set of pulses that came closer together, like a chirp, or you could whatever, right? So it's a pretty cool idea. It turns out modeling this stuff is really hard mathematically, and so whether or not you get a stable solution is questionable. But one thing I want you to recognize here also is you see when you go down a pulmonary vein here and it goes into the lungs, eventually it just stops moving with each heartbeat, right? The vessels, they're buried in the lungs. The atrium contracts. When you're far enough down here, those vessels are not going to move. All right. And then as we go in towards the left atrial myocardium, you can see it's contracting right here, right? So this is contractile tissue here. This is not here. So what happens in this transition is I go from here into the contractile tissue. There's obviously a point right somewhere around right there where you have this huge gradient in strain, right? So basically beyond it towards the left atrium, the tissue is trying to contract. Up in the deeper in the pulmonary vein, it's an anchor. And so that to me would generate shear, like a real gradient in the strain, right? And well, you can also observe that when they go in to try and get rid of atrial fibrillation by ablating tissue, what they usually do is they put a ring of ablations around each one of these pulmonary veins. So they put a catheter here, burn, all the way around to isolate the pulmonary veins. So the arrhythmia often is being generated somewhere in here, right? And you try and isolate this tissue right here in order to stop that. So I would say there's a whole other research direction, which is looking at electrical measurements of the onset of atrial fibrillation in people who have atrial fibrillation that comes and goes. You get data like this when they're not in atrial fibrillation and calculate, like, is there some kind of extreme amount of strain going on here that is generating or amplifying the potential for ectopy. And you can actually cause myocytes to contract just by taking them and stretching them fast. You'll cause
the strain here, you're straining like electrically active tissue.
Exactly. Well, some of it's electrically active and some of it is not, right?
Yeah.
And so the question is this strain, the electrical activation starts down here somewhere and it spreads across the atrial myocardium, right? So question, is this strain causing a hypersensitivity or the ability, amplification of sort of unstable electrical activation? And then if you look at the other side of the left atrium, here we are again. So here's the roof of the left atrium where it's contracting down. Here's pulmonary veins out here, stationary pulmonary vein, and here it's getting yanked on. This is the anterior wall, the one that's really moving, it seems, in your simulations or in your data. And then here is the left atrial appendage, which is like a fantastic little flag that tells you whether or not this atrium is somewhat normal, because the ejection fraction of that little pocket is very high in normal people. So it squishes blood out of this little pocket because you don't want it staying in there in a static way for too long. Patients who are in AFib, this thing just doesn't contract. None of it contracts, right? It becomes a passive conduit. So it will expand when the pressure goes up and the left ventricle causes it to fill, but it doesn't have this active component here. And so what happens is this pocket becomes a potential thrombogenic location, because down the end of it, blood is really in a static kind of configuration, or there's a lot of stasis. You can measure with great detail a left atrial appendage to obtain its geometry. And perhaps, as has been in some of the literature, people say, just given the geometry, we can give you relative risk, of thrombus happening here. I'm not sure I believe that. But you can get a really detailed picture of the geometry, including the orifice through which blood goes into the left atrial appendage from the left atrium. That orifice in folks who are in atrial fibrillation that they can't get out of through drugs, and they seem to be at a high risk through the CHA2DS2-VASc score of having a stroke, they'll put a device. This doesn't show the cloth covering of this device. And they'll put this thing into this hole and block it, right? So they just like stick that in. It's like a plug, and you hope for the best that the tissue around here will endothelialize on this plug, and it just grows into there, and then no blood exchanges between the left atrial appendage and the left atrium. It just blocks it off. Surgically, you can also just cut it off and sew it shut, right? Or you can put a clip across here. Surgically, you can just open it up, put a clip right across here to such that it doesn't have potential to have a thrombus come out of it. This device is called a Watchman, and it became state-of-the-art practice within the last 10 years. It went through a lot of trials, etc., and it's done quite often now. It's placed under X-ray fluoroscopy by an interventional cardiologist who has been trained to put that thing in. CT, by the way, is used in every one of these cases. You do a CT. Well, is that true?
For the Watchman?
For the Watchman, let me take that back. Let me step back on that one. A lot of centers use CT in every one of these cases to get the absolute correct sizing on this thing. If you look at the actual instructions, when you open the box and look at the instructions, they say you have to use transesophageal echo at least to size this, and you do this under TEE guidance. So you're in the cath lab, you're pushing this thing in, and you have transesophageal echo guidance. And so you need, it becomes really expensive, right? You need, excuse me, you need an interventional cardiologist pushing the thing around. You need an echo cardiologist running the TEE, standing there to do it. And then the TEE is marginally good at the sizing. Like, it's pretty good, but it's not great. So I would advocate that everybody gets a, if anybody I knew was going to get a Watchman, I would say you get a CT and get this picture. And so they know exactly what size they're going to put in, because there's about 6 different sizes. Just like a TAVR, and a TAVR is an artificial aorta that they put in under catheter approach, and all of those patients get CT before that goes in order to size it. Here's an interesting data set that we've started obtaining. As you can see, the images are really noisy. However, this is so that the dose of each image is very, very low. But we inject contrast, and the contrast here is coming in the right side of the heart, then going to the left side, and then lighting up this little pocket here. This is the left atrial appendage, which goes up here. It's actually, in this patient, a pretty long structure. And so it starts here. This is their left atrium, and it goes down here. And you can see the delay of contrast enhancement as you move along the left atrial appendage. And so it peaks in brightness over here, but it peaks in brightness over here about 15 seconds later. So we're working on this to get an idea of what is the residence time of blood at some point in the left atrial appendage. Does it sit there for 15 seconds, or does it go in and out really fast? Some patients, this curve across the whole thing just looks almost like the left atrium. So it just goes in, comes out really fast. And so you can look at different curves. Say this blue curve here is Hounsfield unit. So this is just CT number, right? Just pulled right off the CT. This is time in this direction here. And the blue curve, you can see the Hounsfield units start going up early. This is the left atrium. And then this is the left atrial appendage just inside the left atrial appendage. This is the Hounsfield units sort of halfway down the left atrial appendage. And then this is the Hounsfield units all the way down to the end of the left atrial appendage. And so there's this very large gradient of, you know, how the contrast is lighting up the blood at different positions along the left atrial appendage. And I have only one patient here, but we have like 30 of these now. And the variability in this function is quite high, depending on the geometry of the left atrial appendage, on the patient's function, etc. I'm feeling this is much more valuable data than the CHA2DS2-VASc score in determining whether or not somebody should have a anticoagulant therapy. But that is yet to be proven. This is the left atrial appendage and a map of when the contrast starts to light up the signal in the left atrium. So at the left atrium, we're down here, it's I don't know, 5 seconds. This is all about 5 seconds. And then we get into yellow, and at the tip, it's 15 seconds later. And then this is the time at which the signal hits its peak at a different point. Right? So here it's hitting its peak at 30 something seconds, whereas over here it's hitting its peak at, you know, 18 or 20 seconds, something like that. And so that gives you a nice smooth function that is probably correlated with the propensity for thrombus, right? In that, but that all still has to be proven. You know, this is sort of active research. TAVR, which is transcatheter aortic valve replacement, is a really cool new technology and it's been developed over, again, the last 15 years, and it's now done a lot. Because in order to get a new aortic valve, if you have an aortic valve that has a lot of disease, so the valve leaflets themselves are all crusted with calcium and they can't really oppose each other very well anymore. And so when you're trying to eject blood, the actual orifice doesn't really get big enough, right? And so your heart has to really push hard to get it through this hose, which has like a kink in it, and your heart becomes really thick because you're exercising your heart really hard to try and get past it. So you basically want to take this thing out and put a new one in, which surgically you can do. You can just you can buy these valves that are made with pig valves, and you crack your chest, you go in there, you stop the heart, you put the patient on bypass, you cut out the old valve and the leaflets of the old valve, and you just sew in this new artificial valve. And that is a very successful surgery, but you know, if you're really old, it's hard on you, right? Because it's a really tough surgery to get through. And so if you could put a valve in without cracking their chest, right, that'd be great. And so I came up with this really cool device. It goes on a catheter, and it's I forget the exact dimensions, but it's probably 3 millimeters, something like that. It goes, you know, up their femoral artery in their leg and up their aorta to the location of the valve, and then you push it across the valve. And you align it. What's mounted on this catheter is a new valve that's expandable, right? And so then you expand this new valve into the space. And normally you just take the crappy old valve and crush it into the sides here, as opposed to, say, cutting it out first. We just crush it along the sides, and it helps in some ways fix this thing in place. And And so then you pull all this gear out and you're done. Right.
Impressive that it stays in place, especially because that tissue's like moving. It's like
Right.
get the force.
Right. So the comment was, it's impressive that this thing will just stay there and not dislodge and say move up, or dislodge and move into the left ventricle, etc. And sometimes they do, and that's a risk, right? And so they went through a number of iterations of designing these devices such that the skirt on the bottom is the right shape so that it can't really get pushed, down into the aorta. And also it has tines along here such that when you employ it, it kind of sticks to where it is so that it's not going to move either back into the LV or out. So yes, it is impressive. And, kudos to the engineers and everybody who's cycled through various design considerations on here. The one design consideration that's also critically important is if you deploy a valve at this height right here to get past this bad thing, you've got a coronary right here that you have to take into account. And you have a coronary right over here that you have to take into account. You don't want to deploy a device that goes up to here and cuts off the coronary, because then you're toast, right? So you have to somehow have normal coronary flow after this thing goes through. But as you can see, CT is done in every single one of these patients. That CT goes to a 3D lab in which a highly trained technician, or a highly experienced, at least, technician goes through and measures all of these dimensions. This dimension, the dimension from the coronary to where that valve ring is, and given all those dimensions, you decide which device you're going to deploy in that patient.
Is that lab generally like run by the hospital or by the TAVR
Right.
company? Or
so the question is, who runs the lab that analyzes this? And that can be either the radiology department itself has a 3D lab, and that goes into part of the billing, is that you have this analysis post imaging, or if it's a cardiology group, they can do it themselves, right? And every manufacturer like Medtronic, Bard, all these people that make these devices also have experts who are good at that analysis. And the way they became experts is, in the early days of this, everybody had to ship their data back to their company, and the company would double. Even if you're doing your own analysis, the company would always do theirs. And then the cardiologist who's going to do the procedure used to have to look at both. And this caused a little bit of friction sometimes, because sometimes they didn't match 100%. And so there was, a learning curve on that one. But now I think it's been 5 years people have been doing this, but the company, say Medtronic, whatever, would provide that analysis for you if you wanted to get it done. Here's a case. This is a really interesting case. This is going to lead to 3D, some of the reasons why you might want to 3D print something. So here you have a patient with you've seen enough of these aortic valves on CT now to see that this is a mess, right? This thing here, like there's a big aneurysm here. Coronary's coming off, it's got tons of calcium. Here's a coronary coming here. And this is a surgically sewn in valve, right? That has, for whatever reason, come apart from the wall at a number of locations, right? You look around here and you're like, oh my goodness, there's a huge gap here. And so what's going on with this patient is every beat where their heart contracts, blood is going through the valve, but it's also going around the valve, right? It's going around here. And then you're going to get regurgitant leak when the valve's supposed to be shut, to stop blood coming back down the aorta into the left ventricle. Well, that's not going to happen. You're going to have blood coming back down here. So question, what do you do with this patient? Well, one of the proposals on the table was, like, instead of cracking their chest, I think this was a redo. So this patient had their chest had been cracked twice. So now you're looking at it and say, do we go back in a third time the problem with doing that is, after surgery, all this fibrotic tissue happens, and so everything starts to meld together. And then when you go in for the second time, you have to like tear stuff apart, and third time, good heavens, it's going to be not a great show. So the question is, can you go in here in a non quote unquote non-invasive way or with a catheter and try and fix this situation? So what we did was here's the movie, right? And so you can see there's this massive gap here, right? Massive gap back here, right? And so probably what happened is the tissue was not strong enough to hold the stitches, and they just came out, right? Because normally this valve is stitched to the patient's valve ring themselves, and so it probably just pulled off here. So what we did was with this patient, we segmented out the valve and we segmented out the blood and made a model of that, a 3D model, right? And it looked like this. So we have the walls of the valve here, and there's this aneurysm here. Here's the left ventricular blood here, coronary coming up that way. And inside we have what is the surgically implanted valve that exists right now. And these are called amplats, or these are plugs, right? And so if you have say a hole in your septum between your left ventricle and your right ventricle, and blood is squirting through there, and it's causing some, malady because you're mixing all your blood. What you can do is you can put one of these plugs through the hole, tighten it up, and just plug the hole shut, right? And they're used a lot. Question: could you, instead of cracking this guy's chest, just put some plugs in here, right? So the question was, well, what size plugs would they fit in that geometry? You couldn't really figure that out from these pictures, right? So we print this. This is the amplats or the plug rep, and he's got this huge case full of different sizes of plugs, right? And here's the interventional cardiologist. This is one of the guys here at UCSD, going through just one by one and saying, okay, what size should I use? Where am I going to put the first one? How many do I need across here, right? So and then getting cardiologists to come to the computer and sit there and play with digital data and stuff like that, virtually impossible. They are very busy people, right?
Yeah.
But what you can do is when you have this thing printed, you can walk down the hall to the clinic and then hand it to one of the super senior cardiologists who's done many of these procedures, right? And then he looks at it and goes, oh yeah, that's going to work. Yeah, that's good. I think that's going to work. And so that took like 30 seconds, right? As opposed to trying to get on this guy's schedule and stuff like that. So you just do that. And then, so that procedure was done, and that patient did great and is doing great to this day, right? So didn't have to crack the chest. So that's my 3D printing story. There aren't a lot of printing stories, but it's worth having a printer in your lab, I think, for certain situations like this. And then other applications of CT, when you have an LVAD, this is a left ventricular assist device. You can't get anywhere near an MR scanner if you've got a patient on LVAD. But when you're, doing CT, you can just see where everything is, where it's all plugged in and where if it's, in the appropriate place and what the connections are, et cetera. And so I think the great thing about CT also is all of this hardware is completely imageable, right? And you can just make a model of the patient with all the devices in there. Very difficult to do this with echo because obviously metal reflects ultrasound in a wild way, and you wouldn't take this person anywhere near an MR scanner for obvious reasons. Okay, I think that's it for CT applications. Again, I wanted to get through them because I think CT is, it's going to be the principal way people image the heart in maybe 15 years from now. Although I've been wrong before. I did MR, cardiac MR for like 25 years, and it was always 5 years. It was going to be the way everybody did cardiac imaging. Okay. Any questions out there? You can just